if you could please mute your mic so that we can hear everything, and then please don't mute ours, because we really don't want to sign in again. We're the FSSA mic, so please try and not mute our mic. Just as previous meetings go, I will go through the agenda and defer to Dr. Marshall as we move through. And when we get to voting, I will do the roll call voting per usual. You can do aye, nay, or abstain, depending on how you would like to vote. And for public comment, when we get to that section, you can either shoot a message in the chat box, raise your hand, or start talking. We will make sure that you get to provide your public comment at that time. I think that's all the announcements I have, so I will turn it over to Dr. Marshall, who is in person.
Okay. Well, welcome, and I hope everybody has a great NBA weekend. All right. I'm ready. Move on.
All right. Opening comments from OMPP.
We have none.
All righty. That takes us to the approval of the minutes.
Any additions or corrections to the minutes? If not, may I have a motion and a second?
Move to approve. Second.
It's been moved and second to approve the minutes.
All right. Dr. Marshall?
Aye.
Dr. Klass?
I'll abstain.
Okay. Let me mark that down before I forget. Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
I got your eye too, Dr. Treadwell. And Dr. Williams?
Aye.
All right, thank you. We have all ayes and one abstention, so that will carry. The next item we have on the agenda is a consideration for a new therapeutics committee member. I will turn it over to John to give a little bit of a bio first.
Thanks, Amanda. Following the departure of Dr. Ty Sullivan from the Therapeutics Committee, the Office of Medicaid Policy and Planning requests the board consider Dr. Nadia Krupp to replace him on the committee. Dr. Krupp is an assistant professor of clinical pediatrics at the IU School of Medicine and the medical director of asthma at Riley's Hospital for Children. She is a graduate of Yale University, subsequently earning her MD from the University of Pennsylvania. She went on to complete an ENT and general surgery internship at UC San Francisco. She is a board certified pediatrician and pediatric pulmonologist, completing a residency in pediatrics and a pediatric pulmonary fellowship at the IU School of Medicine. She has participated in a number of clinical studies and is an author in several peer-reviewed publications related to asthma in children. What the office most appreciates about her is the reason for this request is that Dr. Rupp has positively interacted with the office, this board, and the Therapeutics Committee on several occasions, advising and advocating for the best care of our patients and our members. We appreciate your consideration of Dr. Krupp.
Thank you. Any questions or concerns? If not, can we have a motion to approve her to the Therapeutics Committee in a second?
Motion to approve.
Second.
It's been moved and second to approve Dr. Krupp to the Therapeutics Committee. All those in, or go ahead, Amanda.
Dr. Marshall?
Yeah, aye.
Dr. Klass?
Aye.
Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
Dr. Treadwell?
Aye.
And Dr. Williams?
Aye.
We have all ayes, so that motion will carry, and we will welcome Dr. Krupp to the Therapeutics Committee.
Could I have a question though, Amanda and John, just for purposes of reviewing the qualifications of the candidate you're looking for, was there, I didn't receive any information or review like a CV or anything like that on this particular matter.
I don't know that one was sent out at all. I mean, I got one. And
I just wanted to make sure I was in the loop and, in case I didn't.
Yeah. I don't know if it's standard practice that we send out a CV, but if that's what the board would like.
We might want to do that.
Okay, that's totally
Did you
fine.
say she did a surgical residency?
Yeah, yep. Well, it's on her CV. So, yes, yeah.
It doesn't make sense.
She saw the light.
No, I mean,
Yeah.
but she's a pulmonologist and a pediatrician.
Right. Again, I could let her talk to that, but
don't
I did
care,
notice
that's
that.
fine, that's just.
Yeah. I did
She
notice
likes
that,
school.
yeah,
She likes school.
Yeah,
I did notice that she did an internship.
that's why I'd like to see the CV to see
Yeah.
what that was, yeah. That's
Well,
just-
I have it, and I will garner her permission, and I
Okay.
will forward it to the board
That's
and
just
have it
pretty
maybe
impressive.
attached to the minutes of. I'm thinking, so with that surgery, she also did an ENT internship, so I'm thinking she kind of got into the kid pathway via that and then went on from there. But that's totally subjective. I have no.
That's impressive.
Yep,
All right.
yeah, it is.
I know Dr. Krupp, and she runs a high-risk asthma clinic where there are a significant number of Medicaid patients, and she has advocated for them before this board previously.
Yep, I agree.
Well, he'll be a good addition, I think.
Yeah, I agree. But I will talk to her and get that sent on to you guys, so.
Okay, thank you.
All right, thank you, everybody. We will then move on to our call center statistics for the month. So for the month of January, overall, we were just shy of 21,000 approved and a little over 8,000 denied. When we look at the silent auth versus kind of manual PAs in the call center, we had 74% approved in silent auth, 26% were denied. Of those that were denied, 22% went to the call center, where 80% were approved and 20% were denied. And then on the manual PA side, we had 57% approved, 43% denied. And if you look at our trending graph, you can see that they were a little up in January. This is not shocking. We have this happen every January. At the start of the new year, we always have more PAs, as well as December tends to be a little bit lower with the holidays. So we do always kind of see a big influx in January. So nothing real super surprising here. We also had some of our changes, our quarterly changes that we had from the PNT in November go in January. So you'll see that reflected in a few of these as well. For the top 10 silent auth requests, we had stimulants, opioids, and antipsychotics in the top 3, which is pretty much what we have been seeing for a very long time and expect to see there. So nothing really changing in that group. For the manual PAs, we had early refills, laxative, and cathartics, which is usually on the list, but usually not this high, and that's reflective of us making some movements around the 1.1 changes, and then the MHQAC utilization edits. You'll also notice that we have the beta-adrenergics and corticosteroids and inhaled glucocorticoids up higher on this list sometimes than they usually are, and that's just reflective of seasonal and illness and things like that. We tend to see them higher during the winter months. Any questions on any of those before I move on to our opioid statistics? All right. So for January, we did have a slight decrease in the total utilizers and then just a slight increase in new utilizers from December, but overall kind of relatively steady. Our utilizers under 18 actually went down to 4.2 days, so they're kind of edging a little bit closer to the 4-day mark. And then you can see our less than 90 is the bulk majority of our patients, and then you can see those in the 90 and above group and those that are PA exempt. And then just graphically showing those in the 90 and above. Again, we've got really small numbers, so that can kind of drastically change the graph depending on where people move. When we look at our overall trending graph, you can see that December and January held pretty steady, which actually I kind of expected January to go up a little bit, just given the month and the longer month, so it held fairly steady with where December was. And then here's our less than 90 MME trending, again holding fairly similar to what it was in December. And then the rest of the trending graph, as far as the other doses, you can see the 500 and above are really relatively low and have gone lower since we've moved people over. You can see that in that 250 to 500, that less than 500, that orange one kind of in the middle, it seems to be trending up, and that's just as we move people down through the chart, you'll see that. Again, really small number of patients in this group, so just a couple of patients can really impact the way these lines look, but overall what we would expect to see, we're seeing happen in the trending. Any questions on any of that before I move on to the mental health edits? All right. So for our mental health edit recommendations, there's a new product, Zurzuvae, that comes in a 20 milligram, 25, and 30 milligram capsule. For the 20 and 25, the Mental Health Quality Advisory Committee is recommending 28 per 365 days, that the age is 18 years and older, and it will have a PA required that I'll go over here in just a second on the next slide. And then for the 30 milligrams, it's 14 days per 365, age 18 and older, and the PA required. And so I'll take this, we'll do it in one vote, and if we need to separate out something, we can. But here's the criteria that will be applied to Zurzuvae. So it's for diagnosis of postpartum depression. Again, we already discussed the 18 years of age and older. They need to be within 12 months of being postpartum, so we need to know their delivery date. And then we just discussed the dosing limit. So the lower dose 20 and 25 is 28 capsules. They could do up to 2 capsules per day for 14 days, and then the 30 is 1 capsule per day. And then, for the 30, for the 1 capsule per day, they need to have a documentation of severe hepatic impairment or moderate to severe renal impairment. Any questions or comments on the Zurzuvae limits or criteria?
Yeah, so once this is approved, is this lifetime? I mean, are they gonna have to re-up on this or what?
No, so it's kind of a per delivery incident. So if you deliver and have postpartum depression, you do a one-time dose of that 14 days. That's all that you do. And then if they would happen to get pregnant again, let's say 2 years later, and have the same incident, they could reuse it at that time.
So that this is only for 14 days?
That is correct.
And then they have to switch to a different antidepressant?
I mean, they can be on a different antidepressant at that point, but the idea is that this is going to take care of their depression during that time.
Right, but after 14 days,
It's about $16,000 worth of therapy.
It's supposed to, I don't want to,
eliminate it completely.
right, I don't want to say like cure, that sounds maybe not the right term to use, but yes, it's supposed to treat their episode of postpartum depression so that they don't.
They don't have it the rest of their, okay, I can't believe that, but okay. $16,000? Is that?
I don't have the exact cost like off the top of my head, but it is quite costly.
Amanda, was there any discussion of putting a step into it with other treatments?
It's mental health,
Yeah.
so.
You're right,
Oh,
you're
so
right.
you can't restrict it then? Oh,
We can put PA around
Right, but
appropriate utilization, but we
you-
can't step
you
through
could-
anything else.
Okay, you can't step through, okay. Holy cow.
Yeah.
Okay.
Dr. Otter, are you trying to talk? You're on mute.
Yeah, I was gonna say, Dr. I see you,
Okay.
your lips moving, but.
Yeah, there's also nothing else like it. I mean, it's an oral dosage form and the only other option is IV.
Right.
So I don't know if step would be helpful.
So what, do you know what the percentage in the studies were that they didn't have any more postpartum depression after taking just 2 weeks?
So it's indicated as an adjunct, right? Amanda, were you talking? I'm sorry, I'm echoing in
I
there.
was just gonna say, we do have the representative from the
What
manufacturer.
do you
who
mean
makes
it's
this
an
product.
adjunct, it's an add-on?
Yeah.
Well, we don't have an add-on here.
Well, that they're on another antidepressant, like an SSRI, you're talking. Dr.
Yeah,
right?
I mean, so they can be on another antidepressant also.
They can, okay.
Yeah.
But we can't make that in there.
Well, we
That
can
they're on
require it if it's in the labeling. So
Right.
in other words, if it adjunct or concomitant therapy is not in the labeling, it's a standalone indication in postpartum. I actually,
Representative?
Did you want to ask,
Yes,
the
yes, I'd
representative
love
is
to hear
here.
about this. 2 weeks of medicine in your bag.
Hi, this is Daphne. I'm from Biogen, and I actually signed up here, so I just make sure I signed up for a speaker. But I was just going to be available for questions. So could you repeat your question?
Yes, what is the success rate after 2 weeks if the postpartum depression was successfully eliminated and they didn't need anything else? And is this a single agent or is this a add-on?
So in our studies, we study as both monotherapy and as add-on. About 15% of patients in our study was on another antidepressant coming into the trial.
What percent, 15?
15.
Okay. And what was the success rate?
Our remission rate, so our study was out to 45 days. At the end of 45 days, our remission rate was about 50, in the 50s, and then our remission rate was in the high 30s, and the response rate was in the 50s. In terms of like 50% of patients responded, about 30 or so percent of patients
30%
remit.
of people got rid of their postpartum depression, while 70% still continued to suffer postpartum depression.
So the remission criteria was defined as less than 7 in the HAM-D17, which is a pretty typical way of defining it. So that's absence of symptoms. Yes, their symptoms went away. But that's pretty consistent with other antidepressants in terms of remission rate. It's, depression is a condition that it's difficult to treat. Not every drug is going to work for every patient.
Too, yes. Yeah, so, especially the kid, it's a lot of work in the first year. That just surprised me, okay?
I have a question. What's the breakdown as far as about 50% of all live births are paid for by Indiana Medicaid, through the Indiana Medicaid program. What is the risk that the state is at? What's the likelihood or the adoption of this? What type of patients out of all live births and postpartum depression, what exposure does the state have with this? Just interesting.
So I don't think we have Indiana specific numbers, but we do know about 13% of women who give birth will have PPD symptoms. But we also know that PPD is a underdiagnosed, undertreated condition currently. So, out of that 13% of patients, not all of them are going to get diagnosed or treated. So our projections was actually around 75,000 patients total in the U.S. So just kind of give you a sense.
So was remission?
But that's not everybody's going to get treated with this drug, right? So that's just 75,000 patients that could get treated with an agent for PPD, but not all of those can end up in this product.
So was remission higher with an add-on or as a single agent, or was it the same?
It's the same. Efficacy was the same.
Okay. And initiation therapy, is it more effective as close to the delivery date, or is it any time postpartum?
So we actually did a post-hoc analysis looking at patients who are less than 6 months post their delivery date versus patients who are greater than 6 months or 6 months to a year. And actually the efficacy is about the same. So even if they're 12 months out from the delivery date, we found this product still works. And I believe I shared some of that with Courtney as well too.
So they can actually be initiated 12 months after they've delivered for this therapy?
Yes, that's inclusion criteria for a trial as well.
Okay.
We were just discussing that the infusion is not long-term either. So I know you're like, the 2 weeks is blowing your mind right now, I can see it. But the infusion for PPD is also short-term, like they do short-term infusion and then they're done also.
Okay. I guess you can't really do anything with it, so, besides that.
Dr. Ott, you look like you might have something you want to add, or am I, okay, just checking. Any other questions or comments? If not, if we could get a motion and a second for this, and thank you for joining.
I'll move to approve.
I will
Do we have a
second.
second? All right, it's been moved in second, Amanda.
All right, Dr. Marshall.
I abstain.
Okay, Dr. Class.
Aye.
Mr. Johnson.
Aye.
Dr. Ott.
Aye.
Dr. Simon.
Aye.
I saw your eye. Dr. Toma.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
All right, so we have all ayes and 1 abstention from Dr. Marshall, so that motion will carry. All right, thank you. We will now go on to our therapeutics committee recommendations. We will go through these by therapeutic categories. So first up, the respiratory recommendations. The therapeutics committee has no recommended changes in the classes listed here. For the beta adrenergics and corticosteroids, the Advair HFA 230 per 21, maintaining its current status and removing its step therapy. And you'll see us also do that in the 500 per 50 dose as well. We don't have any step therapy around high dose products anymore. I think this kind of was an artifact for when those products were much higher cost. And so we're just gonna allow people to kind of move through the doses as they need to. For the Air Duo Respiclick, moving to preferred and maintaining its current quantity limit of 1 inhaler per month. For the Air Supra, it is a new albuterol combination product with budesonide, adding to non-preferred with age limit of 18 years of age and older and a quantity limit of 2 canisters per 30 days. For the fluticasone salmeterol, which is the generic Advair 500 per 50, as I mentioned earlier, maintaining its current status but removing its step therapy requirement. For the nasal antihistamines, nasal anti-inflammatory steroids, for the azolastine fluticasone, moving to non-preferred and adding generic medically necessary PA criteria, and then its brand product Dimista moving to preferred and adding it to the brand preferred list. For the respiratory and allergy biologics, Dupixent has a new indication, so maintaining its current status but updating its age limit for eosinophilic esophagitis to 1 year of age and older and weighing at least 15 kilos. And that concludes the respiratory.
Any discussion? If not, can I have a motion and a second to approve the changes in the respiratory?
This is Chris. I
Move.
move to approve the changes.
Second.
Second? It's been moved and seconded to approve the changes in the respiratory class. Amanda?
All right, Dr. Marshall?
Aye.
Dr. Klaas?
Aye.
Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
Dr. Treadwell?
Aye.
And Dr. Williams?
Aye.
All right, we have all ayes, so that motion carries. Thank you. For the anti-infectives, there are no recommended changes in the classes listed here. For the hepatitis C agents, there is a recommendation around updating the PA criteria, and this is around previous treatment history, so requiring HCV labs and genotype be obtained within the past 6 months. And the reason that this is coming up is we've had some situations where either prescribers didn't know somebody was previously treated, or maybe they received a month but didn't take any more, and so there's not a lot of knowledge of what's happening there, or if they're still the same, if they were reinfected or not. Also, we do have people that spontaneously clear the virus, and so if it's been a significant period of time since they've had blood work done for that, we would like to have that again just to verify. For the PEG Intron, it is no longer manufactured in CMS terms, so removing that from the SGPDL. For the macrolides, the EES granules, maintaining its current status but updating its step therapy around needing to trial and fail the erythromycin ethylsexonate suspension in the past 90 days, or the member must be 12 years of age or under or unable to swallow the tablets or capsules, or the prescriber has provided valid medical justification for use. This is similar to what's there now, but it's really looking at around that trial in the past 90 days, so that if somebody needed therapy again and it's like a year later or some time period later, you could at least say at that point, hey, are you still unable to swallow tablets, capsules, or do they still fall in that age range, or why wouldn't this other product work for you? All right, for the ophthalmic antibiotics, Moxiza is no longer manufactured in CMS term, so removing that from the PDL, but the generic moxifloxacin is still available. For the otic antibiotics, the colimycin S is also no longer manufactured in CMS term, so removing that from the SUPDL. In the vaginal antimicrobials, we have a product Zacchiato, as I like to call it, because it makes me think of caramel macchiatos, recommending adding to non-preferred in the antibacterial subcategory. And that concludes the anti-infectives.
Any discussion of the anti-infective class? If not, may I have a motion and second?
So moved.
Thank you.
Second.
I'll second.
Okay, it's been moved and second Amanda, for the
All right.
anti-infective class?
Dr. Marshall,
Aye.
Dr. Class,
Aye.
Mr. Johnson,
Aye.
Dr. Ott,
Aye.
Dr. Simon,
Aye.
Dr. Toma,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. On to the cardiovascular recommendations. No recommended changes in the classes listed here. For the ACE inhibitors, the Cubrellis solution, maintaining its current status but updating its 8-step therapy to be 6 years of age or older and less than 12 years of age or unable to swallow tablets. You'll actually see several of these that we're updating around the step therapy for the ability to swallow in the age range. So valsartan solution in the angiotensin receptor blockers, updating or adding the step therapy around must be 6 years of age and older and less than 12 years of age or unable to swallow the tablets. And valsartan solution will be added to non-preferred. For the beta-adrenergic blockers, hemangiol maintaining its current status and updating its step therapy to must be 5 weeks of age or older and less than or equal to 1 year of age. For the calcium channel blockers, for Catersia, maintaining its current status but updating its step therapy to be must be 6 years of age or older and less than 12 years of age or unable to swallow the tablets and a previous trial and failure of Norleakva or medical rationale for use. And then for Norleakva solution, maintaining its current status and updating its step therapy to must be 6 years of age and older and less than 12 or unable to swallow the tablets. And then Nymalized solution, maintaining its status, and then step therapy must be 18 years of age or older and unable to swallow the capsules. And that concludes the cardiovascular.
Any discussion, the cardiovascular section, if not, or class? If not, may I have a motion and a second?
This is Kelly. I move to approve.
I'll second.
It's been moved and second, Amanda, to approve the cardiovascular class.
All right, Dr. Marshall,
Aye.
Dr. Class,
Aye.
Mr. Johnson,
Aye.
Dr. Ott,
Aye.
Dr. Simon,
Aye.
Dr. Toma,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, perfect. We have all ayes, so that motion will carry. And as I told the therapeutics committee, I think this is the first time I've ever been able to do this for this group, but in the lipotropics classes, we have no recommended changes in any of them.
Any discussion? If not, may I have a motion second for the lipotropic class?
Motion to approve, no changes.
Second.
It's been moved and second to approve the lipotropic class, Amanda.
Dr. Marshall,
Aye.
Dr. Class,
Aye.
Mr. Johnson,
Aye.
Dr. Ott,
Aye.
Dr. Simon,
Aye.
Dr. Toma,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, thank you. All ayes, so that motion will carry. On the anti-migraine recommendations, for elatriptan, maintaining its current status and quantity limit, but adding to the generic medically necessary PA, and then its brand counterpart Relpax, maintaining its current status and quantity limit, but adding it to the brand preferred list. And then for the sumatriptan nasal spray, moving it to preferred and maintaining its current quantity limit, and the zolmitriptan nasal spray moving to non-preferred with its current quantity limit, and allow those with a history of use in the past 90 days to be able to continue therapy. And that concludes the anti-migraine.
Any discussion on the anti-migraine class? If not, may I have a motion and a second?
Move to approve.
This is Chris. This is seconded.
It's been moved and second to approve the anti-migraine class, Amanda.
Dr. Marshall,
Aye.
Dr. Class,
Aye.
Mr. Johnson,
Aye.
Dr. Ott, Dr. Simon,
Aye.
Dr. Toma,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
Thank you. We have all ayes, so that'll carry. I saw your eye, Dr. Ott, if you were thinking that I took it as a motion, or I took it as an aye. All right, for the electrolyte depleters, for the Fosrenol Chew, removing from the SUPDL and brand preferred list as it's no longer manufactured and CMS termed, And then for its generic, the lanthanum carbonate chew, maintaining its current status and removing the generic medically necessary PA criteria. So basically now that the brand is no longer available, we can't require the brand. For Foslera, it is no longer manufactured in CMS terms, so removing that from the SUPDL. Zefoza is a new phosphate binding, or similar to phosphate binding products, and recommending adding to non-preferred and a miscellaneous agent subcategory, since it technically isn't a phosphate binder. And then step therapy around must have trialed and failed preferred phosphate binders or submit medical rationale for use over all preferred phosphate binders. It is more of a second to last line therapy after they've tried other therapies. And that concludes the electrolytes.
Any addition or any discussion of the electrolyte depleter class? If not, may I have a motion and a second?
Amanda, I got a question. At the risk of admitting I didn't attend the acronym orientation here to this role, SUPDL?
Is single unified preferred drug
Okay,
list.
okay.
Any other discussion? If not, may I have a motion and a second for the electrolyte depleter class?
Motion to approve.
Second.
It's been moved and second to approve the electrolyte depleter class, Amanda.
Dr. Marshall,
Aye.
Dr. Kless,
Aye.
Mr. Johnson,
Yes.
Dr. Ott,
Aye.
Dr. Simon.
Aye.
Dr. Toma,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. For the multiple sclerosis agents recommendations, for Tysabri maintaining its current status, but updating its Crohn's disease indication to allow for Rinvoq trial to be considered for its step therapy requirements, since Rinvoq has that indication as well. And that concludes the MS.
Any discussion on the multiple sclerosis class? If not, may I have a motion and second?
I'll move to approve. Second.
It's been moved and second to approve the multiple sclerosis agent class. Amanda?
Dr. Marshall.
Aye.
Dr. Klass.
Aye.
Mr. Johnson.
Aye.
Dr. Ott.
Aye.
Dr. Simon.
Aye.
Dr. Toma.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Aye.
We have all ayes, so that motion will carry. Thank you. For the targeted immunomodulators, we have a lot of biosimilars happening here for the adalimumab, so bear with me as we go through several of these and place them. So for Abrelata, adding to non-preferred and the non-preferred two-step Silenoth criteria. The adalimumab AACF, adding to non-preferred and non-preferred two-step, along with the adalimumab ADBM, and adding to non-preferred and non-preferred two-step. For adalimumab FKJP and Hadlima and Humira, maintaining their current respective statuses, but for Crohn's disease indication, removing the infliximab trial from approval criteria. For Adbry, maintaining its current status, but updating its age limit to 12 years of age and older for the moderate to severe atopic dermatitis indication. There's a new product, Bimzelx, adding to non-preferred and adding to the non-preferred two-step Silenoth criteria. For Cosentyx, maintaining its current status, but updating criteria to include hidradenitis suppurativa indication with a step through the preferred adalimumab agents or rationale for use of Cosentyx over the preferred agents. Idaccio is another adalimumab biosimilar, maintaining current status and adding non-infectious uveitis indication to its approval criteria since it just had it added. Omvo is a new product adding to non-preferred and adding to the non-preferred two-step Silenoth criteria. And then Alaris maintaining its current status, but it has a new indication for the treatment of symptomatic gout or flare in whom colchicine, corticosteroids, and or NSAIDs are contraindicated or have provided inadequate response to criteria. Velsipity is a new product, adding to non-preferred in the non-preferred two-step criteria, but including one of those steps should be through Zeposia and one other targeted immunomodulator agent. For the Xeljanz solution, maintaining its current status, but updating its step therapy around its age, so member is 2 years of age and older and weighing 10 kilos or more and less than 18 years of age and weighing less than 40 kilos, or the provider has submitted documentation supporting inability to swallow the tablet formulation. And then on another biosimilar, the Euflema, maintaining its current status and adding the non-infectious uveitis indication to its approval criteria since it just had it added. So I know that was a lot. Any questions or comments on the TIMIs today?
If not, may I have a motion and a second for the targeted immunomodulator class?
Amanda, I do have a question with the biosimilars. Is consideration being given on those biosimilars that are interchangeable with the brand product?
Yes, so when we review the biosimilars, there's several things we're looking at. The first thing is, are they, do they have all the same indications that the originator product has, if they have interchangeability or not? If they have, there's also high concentration and low concentration, so we take that into account to make sure we have both of those covered on the preferred side, and then obviously we look at pricing as well. So we do think things will shift with biosimilars here in the future as we go. They've obviously exploded. We started with, just a couple that trickled in, and now we've got what seems like 1 million that are on there already. So I'm sure there'll be more movement in the future, but we do take all of those things into consideration and make sure we have all the indications covered on the preferred side so that we're not eliminating something there that we shouldn't be.
For the adalimumab, do we have a product that is in an 80 milligram dose? That we do have that, okay.
Mm-hmm. So we have both high concentration and low concentration. So Humira has the high and low, and then I'm pretty sure Hadlima has the high and low.
Okay, so we still have Humira. I thought I saw the Humira in non-preferred, but I guess I'm wrong.
And then I think the adalimumab that's FKJP, I'm pretty sure is low concentration, if I remember.
That's
correctly.
Hadlima?
Hadlima has high and low both.
Oh, they do, okay.
And then the one that's just the adalimumab FKJP, that's the preferred, I'm pretty sure is low concentration, from what I remember. But we definitely have both covered. Any other questions I can answer? Okay.
Can we have a motion and a second then for this class?
This is Chris, I motion to approve the changes.
This is Carol, I'll second.
It's been moved and second to approve the targeted immunomodulator class, Amanda.
Dr. Marshall?
Aye.
Dr. Klass?
Aye.
Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
Dr. Treadwell?
Aye.
And Dr. Williams?
Aye.
Thank you. We have all ayes, so that motion carried. One of these days, I'm going to change up the order on you guys and then really take you all by surprise. All right, that concludes our Therapeutics Committee recommendations review. So that takes us up to then any managed care updates today. I'm looking at Beth and Cindy only because they're right in front of me, but anybody on the phone equally have anything? Okay, I'm hearing nothing. All right, that takes us to new drugs then, which I do have something for us to review there. So there is a new muscular dystrophy agent, Agamree. We're a little not totally sure how it is. I probably should ask somebody sometime. So for initial authorization, must meet a diagnosis of Duchenne muscular dystrophy confirmed by genetic testing. The member is 2 years of age and older, and the requested dose should not exceed the 6 milligram per kilogram per day, with a max of 300 milligrams per day or 2 bottles every 25 days. And they round that to the nearest 1/10 of a mil of the oral suspension once daily. So we'll have to look at their weight to make sure that we're reviewing that appropriately. And the prescriber has provided documentation of their current clinical status to compare upon reevaluation. So we list some of those there. And then in the reevaluation, looking at a history of the requested agent in the past 90 days, documentation from the prescriber indicating improvement or stabilization in their current clinical status, And then again, same requested dosing. And then on the Emflaza, updating its criteria around the diagnosis of Duchenne muscular dystrophy, so just requiring the documentation like we do in the Agamree. Any?
Are these drugs to compete with the other one?
So no, these are like the steroid-like products. They are not competing with the other
So are they
agents.
used in combination then?
No, I'm pretty sure that they,
could be, yeah.
but I don't know that we
Yeah, they could be.
see that very
Yeah.
often though. I feel like they only use one
Are
of them.
these long-term or?
They can be long-term, yes.
Yeah, you typically wouldn't see the steroidal therapies and an immunomodulator added into that. They both are doing essentially the same thing.
Because I thought the other one, that's the other one, what did we do with the steroid? Wasn't the other one involved with a steroid too?
You're thinking of the one where they had to use some sort of steroid, corticosteroid prior
Right,
to
Yeah, that's the
administration
gene
of that
therapy.
product.
Yeah, the big one.
Yeah.
But these are different than that one,
Correct.
and you wouldn't use them in combo. Well, why would you use one over the other? Does anybody know? Why would you use these versus the other one? The one that, the
So
Elevis,
these-
or what is it, Elevis or something?
Well, the Elevities is a cure.
Elevities. Is what?
A cure.
Okay.
It's a gene therapy cure.
And then what are these?
These are not cures, they are treatments.
Yeah,
So,
To stabilize?
yeah.
treatment.
Yeah.
Mhm.
And you're gonna have a lot of patients that are not candidates for the gene therapy.
Oh, really?
Yeah.
Oh,
So,
okay.
Yeah,
Okay, so you would use these for those people?
that's correct.
Okay, all right, thanks.
Any other questions we can answer on that one before I move on to the next thing? All right. For the non-SUPDLPA and step therapy criteria for the indomethacin suspension, they need to be 15 years of age and older and unable to swallow the capsule formulation. And then the reauthorization would be that they've had history of the requested agent in the past 90 days, and again, still unable to swallow the capsule formulation. And that concludes our new drugs. Any questions or comments on those or concerns? If not, if I could get a motion in a second, please.
Move to approve.
Second.
Aye.
Dr. Klaas,
Aye.
Mr. Johnson,
Aye.
Dr. Ott,
Aye.
Dr. Simon,
Aye.
Dr. Toma,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes there, so that motion carries. Thank you. Any liaisons with other boards today? All right, I am hearing none. Did we see the, I think there's public comment signed up back there. We're going to check the public comment in the room, but was there any public comment on the phone? If you want to shoot a message in the chat box, you can raise your hand. I see a hand raised there, so let me capture the room first, and then I will get over to you. So, okay, she's saying no. So the person who already spoke, Dr. Nee, if you have any other questions for her, I'm sure she would get up and be happy to speak, but otherwise, she is good. Good luck with
That's a
that.
good question.
All right.
Wow.
So let's move on then to our public comment on the phone. I'll see if I can get my
Thank you for what you did.
timer to go here. All right, so I see Lisa Sershone on the phone that would like to provide public comment.
Yep, that's correct. Thank you so much for the opportunity to be on today. Sorry, I can hear the echo.
Oh, you're fine on our end. We hear you just fine.
Okay, sounds good. So good morning, I'm Lisa. I'm a medical science liaison with CG Therapeutics, supporting Briumvi for relapsing MS. I've been in the multiple sclerosis therapeutic area for the past 12 years as a clinician and an MSL. And I'm here this morning to encourage adding ublituximab to your preferred agents alongside the other available anti-CD20 therapies. Multiple sclerosis care and treatment have significantly advanced in the past 15 years, and based on this accumulating evidence, high efficacy early treatment, including B-cell therapy, has become the standard of care in MS. Reduced accumulation of disability and disease activity with highly effective DMTs leads to fewer healthcare economic burdens and allows people living with MS to continue to be productive members of society. So
Lisa,
BRIUMVI
can I
is a
interrupt you?
Yep, go ahead.
Just a quick second. What's the drug again? We missed that part. We couldn't hear very clearly
Sorry.
on that.
Yep, and it's hard for me to hear because the echo's really bad. But BRIUMVI is a anti-CD20 therapy for relapsing MS.
Is that on here? How you spell it?
It's BRIUMVI.
BRIUMVI.
Is that on here?
I'm looking, I'm sorry.
We're checking really quick.
Okay.
Yeah, it's already on there as on the non-preferred side, commercial.
It is on here? I don't see it on here. Oh, it's on the non-preferred, but it's not on here.
It should be on the PDL side, but it wasn't a new recommendation.
Right, but I don't see it on the non-preferred list.
BRIUMVI, it's non-preferred.
Oh, is it? On the non-preferred? A targeted modulate, oh, MS, that's the problem. All right.
Yeah,
Give
it's
her
the
another-
first one on the non-preferred.
Okay, go ahead, give her more time, we screwed it up.
Yeah, well, I'll let you continue. Just go right ahead.
Okay, thank you so much. So BRIUMVI is a unique glycoengineered B-cell therapy. The glycoengineered component of the antibody allows for more efficient B-cell depletion, potentially fewer infusion reactions, and shorter infusion time. The maintenance dose of ublituximab or BRIUMVI is every 24 weeks with a 1-hour infusion time. And many multiple sclerosis patients have considerable symptomatic burden, including neurogenic bowel and bladder, spasticity, sensory disturbance, and neuropathic pain. And therefore, less frequent dosing and time in the infusion chair can improve medication compliance, infusion experience, and quality of life. So ublituximab was studied in 2 large phase 3 clinical trials against teriflunomide. The primary endpoint was annualized relapse rate. In both trials, the AR in the ublituximab treated group was about half the rate of the teriflunomide group. For MRI activity, ublituximab reduced the mean number of gadolinium-enhancing lesions by 96%, and the mean number of neuroenlarging T2 lesions by 91%. 95% of patients experienced no confirmed disability progression. So BRIUMVI was also thoughtfully priced, and before coming to market, the company met with payers and key stakeholders to ensure patients could access BRIUMVI, and intentionally came to the market as the lowest cost anti-CD20 in MS. So in closing, BRIUMVI is a unique glycoengineered B-cell depleting therapy that can be administered in lower doses with a shorter infusion time than other infusible anti-CD20s such as ocrelizumab. And the 1-hour infusion may improve the experience and convenience for patients, their families, and clinicians, with the added benefit of having the lowest annual maintenance wholesale acquisition cost of any branded disease-modifying therapy in MS. So please consider adding BRIUMVI to your preferred medications for Indiana Medicaid.
Thank you.
Thank you.
Thank you for the opportunity to comment.
Does this formulary have jurisdiction over medical services? Because this is typically something that's administered in a...
Actually, it's interesting you say that. We are actually initiating some of the preferred agents on the medical side that we have not to date. We have, I wasn't going to talk about that until we were a little bit further along, but it's coming. So
would BRIUMVI be one of those, or would that be something that we would pay through medical claims?
I have an initial list of 31, to be honest with you. Off the top of my head, I couldn't recall if it was on it or not. Okay. So, very good question. And I'll throw in, by the way, that probably within the next several sessions, you're going to start to see some anti-cancer agents as well that you're going to be reviewing the PA criteria for.
will we be able to understand that as we review some of these things? Because I was, when the presentation was Granby, I was like, why would we be considering that an ambulatory formulary, right? Or
Well,
preferred drug list, right?
because some of these drugs can be given in the clinical setting. I mean, the outpatient setting, I should say. So, and they have pharmacy claims to process through. So, we have a lot of injectables that happens with.
Okay.
All right. Any other public comment? Again, you can raise your hand, start speaking. I didn't see anything in the chat. All right, I'm hearing and seeing none, so that will take us to old business. Any old business? All right, any new business before I cover mine? All right, I will get it started then. So this is an FYI only for the SUPDL update. The generic Advair Discus moved to preferred on 1/24, and the brand Advair Discus is being maintained until 3/1. This has to do with some availability issues, and so we're working through that. On the contraceptives, Zafemy, maintaining its current status and adding step therapy that it must have a previous trial of all the preferred patch formulations or of contraception or medical justification for use. And then for the SGLT2 inhibitors and combinations and PFA, maintaining its current status with step therapy that it must trial and fail each of the following active ingredients as monotherapy or combination product: canagliflozin, dapagliflozin, empagliflozin, or medical justification for use. For the brand preferred list updates that will be for implementation on 4/1, additions, we're looking at Grelease, Korlym, and Prolenza, and then removals, we have Diovan, Prozista, Prestique, and Rosarum. Any questions on the new business or anything that I can go over?
So those removals from the brand list, we have their generic.
Yeah, it's just that we're not going to prefer the brand over the generic for those products. Oh, okay. Let's finish this out and then we'll, okay. All right, if there are no other comments, if I could get a motion and a second, please.
Move to approve.
All right. I have a motion and a second. Dr. Marshall?
Aye.
Dr. Klaas?
Aye.
Mr. Johnson?
Aye.
Dr. Ott?
Aye.
Dr. Simon?
Aye.
Dr. Toma?
Aye.
Dr. Treadwell?
Aye.
And Dr. Williams?
Aye.
All right, we have all ayes, so that motion is approved. And it looks like we have a comment on the line about addressing some of the questions around the medical drugs from Giovanni. So if you would like to go ahead and...
No, absolutely. Hi there, TR. Hi there, Chris.
Hey, Gio.
Giovanni Bonilla, Director of Clinical Operations for ONPP. So I am accountable for the pharmacy operations, with Leslie Lugo. So the medical drugs, a lot of the physician administered drugs under the federal regulations, if it's an outpatient drug, including an infusion that could be administered in the outpatient setting, once that becomes rebatable, we have to cover it, right? That's kind of like a mandate. Now, the issue that we're having is with some of the medical drugs that are going to be inpatient only, with some of the Vertex, for example, and some of the sickle cell drugs. Those are being reviewed outside of this board because those are inpatient drugs. We are not required by federal regulations to cover those medications. However, we do feel that it is medically appropriate when do so to do coverage. So Dr. Sullivan, who now assumes the role of medical director for our department, he is working with Dr. Zayer and other clinicians, including our managed care entities. Now, because those medications could be $2.8 million, $3 million per administration, right? We are looking at how we're going to cover those medications, reimburse you know, whether it's a DRG outlier. So there's a lot of work happening in that space. So the DUR board will continue to review all medical drugs that could have a pharmacy claim. So those will continue to do is the inpatient drugs that will not be reviewed through the DUR process.
Thank you very much. Any questions?
Thanks.
Or you look like,
So with the coverage of outpatient infusions, was that kind of a new guidance, or that's always been? We
that's
just
always
never-
been, yeah, so
the
anything
State's
that,
never had any limitations on outpatient.
anything that you could get shipped out of a pharmacy that would go, you know, where a patient could take it or something like that, we've always reimbursed for it.
Right. So, but if they have to go to an infusion center, into a facility, is that still under?
That's still outpatient.
That's still outpatient, okay.
Yeah.
Okay.
Well, a good example would be Hemgenics. Hemgenics can theoretically be administered through an IHTC outpatient clinic type of thing. And so that's why we have brought Hemgenics to you guys for the criteria approval, so, yeah.
And so now you'll be able, is there any chance of recouping a lot of rebate that you might have paid through paid claims in the history?
If you were a manufacturer selling a really expensive drug and it was the only one out there and it cured a disease, would you offer a great deal of rebates? That's the only question the only response.
I just thought if it's part of being part of the covered services.
Well, I mean, they have to pay the federal rebates,
Right.
but as far as the supplemental, there's just not.
There is several states and groups, including Indiana, I know, that are looking at value-based contracting for genetic products around if they have a cure or not, and if not, you know, then some level of reimbursement back for that. So far, there's still some manufacturers that I don't think want to fully put their money where their mouth is and say if it doesn't cure, that we'll pay the full cost back of the drug, but it's being worked on in a lot of groups.
So are we?
We are actively looking at those.
And being able to invoice those for rebate?
Once we get them set up. So,
They've always been invoiced for federal rebate.
yes,
All the medical infusions?
yeah.
Or physician, yeah.
Yeah, Chris, in order for it to be covered by the state Medicaid program, it must have a HCPCS and it must have entered into a rebatable agreement under the feds. Otherwise, the state is not required to cover it.
Yeah, I understood that, Joe. I didn't realize that we were taking medical claims for those types of drugs and including them in our rebate invoices, so. Nice.
Any other questions? Thank you very much for the information. All right, any other new business?
I'd just like to say it's nice to see TR, his face.
It's snowy.
Yeah.
Did it snow?
Oh, it's not, or it is. It is snowing?
No, not yet.
I know it's really close according to the radar, so.
Oh, yeah. Okay.
I think Dr. Marshall's ready to go hit the basketball courts
Exactly
here
right.
really soon,
It's gonna
so
be a great weekend here.
I will turn it over to you, Dr. Marshall, for our last item on the agenda, which is adjournment.
Yes, we're adjourned. Thanks. Good seeing everybody. Come down and join me sometime.
Thank you, everybody. Have a great weekend. Thanks for
Thank
bearing
you,
with
too.
us on our IT issues.
Bye-bye.
Thanks. Bye-bye.
So how much weight do you guys lost? You guys look good.